أهلا وسهلا بكم. بسم الله الرحمن الرحيم. نبدأ. This is going to be part 2 من السيريز بتاعت الكولايتس, and I hope that you will find this in continuations مع المحاضرة اللي فاتت useful, إن هي توضح بعض الأمور المبهمة إن شاء الله بإذن الله تعالى. هي الفكرة زي ما قلنا الأسباب اللي بتخلي ال area of colitis confusing, that we are dealing with a small biopsy, but you are trying to get a diagnosis, one of those ones which has got a lot of overlaps between them. يعني في شبه كتير ما بين الأكتيف أو الأكيوت كولايتس والألساتيف كولايتس for example, ما بين الدايفرتيكولار ديسيز والألساتيف كولايتس, ما بين الإسكيميك كولايتس for example والراديation colitis. They have some similarities between them. So what I'm trying to say is that there is an overlap and we all know that. والمشكلة التانية زي ما وضحنا إن هو في symptoms كتير, signs كتيرة لازم to look into it in a very short span of time, لأن في الأول وفي الآخر يعني إحنا مش عايزين إن إحنا نقضي نص اليوم بنحاول إن نحل اللغز بتاع الفزورة بتاعت البيوبسي جي آي, في حين إن عندي أكوام يعني فوق بعضيها من بقية الحالات, فبالتالي ساعات بيبقى السرعة against these slides, لأن you can miss a lot of those when you are trying to interpret at a very high speed. فديت نقطة تانية تخلي الكونفيوجن موجود. النقطة الثالثة بالنسبة للكونفيوجن هي إن إحنا ساعات بنتعلم إن it is إن الجبن سيد الأخلاق. أوكي, فبما معناه إن هو if we stay by the chronic colitis or chronic active colitis, then there is nothing wrong in this report, وخلاص we authorize it, we send it to the clinicians. لكن كل مرة يجيلك biopsy من نفس العيان, you give the same diagnosis, لكن it doesn't help the clinician at all, لأن he knows إن في chronicity. الكلينيشن نفسه عارف, لأن الأعراض بقالها 8-9 شهور عند العيان, وبعت لك 3 sets of بقى 3 endoscopy و3 biopsies, and you still every time you give the diagnosis of chronic colitis or non-specific inflammation, it is if this is your character, then do everything else but leave the inflamed GI biopsy to someone else. Don't try to do it, لأن that's not right. يعني you're not doing any favor للعيان in general. وقلت النقطة الرابعة اللي بتعمل confusion هي إن في معظم الليكتشرز والسيمينارز اللي إحنا بنحضرها في conferences, في workshops بنقراها في الكتب, everywhere people don't try to pay a lot of attention to the details of what we mean by the word crypt distortion. وساعات احنا بننظر لها نظرة very general, and we don't really look into the depths of details regarding this complexity of the. and المرة اللي فاتت بدأنا نتكلم عن بعضهم لكن ما لحقناش نخلصهم, وكلمنا على الكريبت برانشنج وباستفاضة, وقلنا الكومبلكسيتي of the crypt branching مهمة, والفريكونسي of the crypt branching as well مهمة. يعني حتى لو كانت simple branching but in a lot of high frequency, this can make a lot of difference. But if it is complex, then it speaks about itself in general term. وكلمنا على الكريبت dilatations وقلت لكم it is good sometimes to compare the caliber in relationship to the surrounding crypts, and then you can judge if it is dilated or not. And I said try to go a little bit toward the mid or the base of the crypt rather than staying in the surface، لأن ساعات يكون ما تبقاش واضحة 100% لما بنشوفها بالطريقة ديت. So when you go للbase of the crypt and you see that it is dilated, then it gives you a good indications of that term that we call it crypt dilatation. So sometimes the dilatation might happen mainly toward the base of the crypt rather than the entire crypt is to be dilated. And then we give more examples last time of this crypt dilatation. Here in this example, the whole crypt is really dilated. So that is absolutely fine. وبعد كده هو برضه اتكلمت عن الهوريزونتال والاوبليك crypt alignment. And this is crypt is very obliquely aligned. So this is on its own is a crypt distortion. وقلت لحضراتكم this is a little bit different from this crypt here over there, that crypt over there, which I use the term more of angulation in this one. لكن this one it is more of an obliquely orientated crypt. So this is just to highlight this in that term, and you can get a horizontally aligned crypt when it becomes more like here we have an example of oblique crypt, while here we have a little bit horizontal, trying to really be very parallel to the surface somehow. So this is what we mean, but sometimes these findings can be very subtle and you just have to see it. But here's another good example, horizontally aligned crypt, and this is on its own tell you that I am very distorted in, or there is a crypt distortion. Like I also warned you when you apply these features that you have to assess it in the direction of the biopsy. فبالتالي if you have a biopsy that looks like this, and then you have another surface here, and then you have another surface here, then you have to judge the crypt in relation to the nearest surface. So فبالتالي I cannot call this one horizontally aligned, لأن in relation to this crypt, it's actually vertically aligned and it is absolutely fine. Yes, this one is horizontally aligned for this surface, like you are looking then, or you're comparing it to the wrong surface. So make sure that you don't get caught in the middle of this. And it's a simple thing, but it's in the, again, when you are rushing, it is very easy to get into this. And then we stopped here, I think, المرة اللي فاتت, which are still continuations of what we will call it crypt architectural distortion. And there is another features here, we call it tortuosity and angulation. So I will show you some examples. So this crypt now started to form an angle, and if you really put a degree here زي ما اتعلمنا في الهندسة, then this angle is nearly about 90 degrees. So this is really an angulated crypt. And to a great extent, this is a crypt architectural distortion for me. You don't really see that normal in the normal mucosa, and you have to really just pay attention to subtle things like this, especially if you don't have a lot of inflammation. Of course, in this example, you have a lot of inflammation, then you can weigh it in the middle of all of that. لكن يعني in a case like Crohn's disease sometimes, or quiescent colitis, when the inflammation resolves or it is present but very focally, then something like this might solve the puzzle for you. And I will try to show you some examples like here, right? So this case, for example, it is a Crohn's disease case. Yes, so this is a Crohn's disease case, and what you will see that the gradient of the inflammation is fine. Okay, فبالتالي it is heavy on top, getting very light in the bottom, and we are absolutely fine. Lekin, if I am to look into this crypt in the middle, this crypt is very angulated, and then there is also branch crypt which is present next to it here. So this is the problem, and I think this is the problem of a lot of studies. You see, when they tell you in the majority of Crohn's disease don't have a crypt architectural distortion witnessed, it is different. There is a crypt distortion in Crohn's disease. Like if I look here, there is a crypt bifurcation here, and there is another one here, and there is a third one there, but it is easy to miss it. You see, so you can for sure miss something like that. And that is the whole idea that when then you make a big study and you find that the pathologists have written that there is no architectural distortion, it's probably was there, but it is subtle, and or probably it was there, but the general pathologist in general, they don't tend to pay these hours and hours to try to figure out is there is a crypt architectural distortion ولا ما فيش. فبالتالي sometimes they just put it as a Crohn's disease because they saw granuloma, لكن the comments on something like this as there is no architectural distortion. لكن هنا هو في الحالة زي كده هو there is a crypt architectural distortion based on something like that. Here is a different story, of course. This is here, we have got what you call it a Toshua script. It is like a Toshua, like trying to go right and then go left and then right again and then left again. So this is really a Toshua script. Like in في نفس الوقت next to it here, you have another crypt that's showing you this 90-degree angulation. You see, it is even in this view where you see the crypts into this, you might be able to hear again another crypt showing this angulation. It is still possible, whatever orientation your biopsy is showing, to be able to see this angulation, and then you will be able to say, yes, there is a crypt architectural distortion. So this is one of those things. And then I told you that you have this also what we call it the tortuosity of the crypts. Like the crypt is trying to be like a spiral in a way, or trying to curl around itself somehow. It is really it needs a lot of imagination, this, but it is there. This is what you call it a tortuous crypt, and this is also a form of an architectural distortion that's not really like a proper branching now. This is not an angulation. This is not, if you're not familiar with this term tortuosity of the crypt, then you might miss it into this format. This is when it is more stretched, but you can see the lumina. I will just go by the lumina and you can see the tortuosity of the lumina. So this is what you call it a Toshua script. This is not like a straight line like this side here where you can go by the lumina and find it very straight. This one is a little bit tortuous in terms of the directions. And this is a quite important finding here. You can see other features of architectural distortion, like crypt dilatation at the base. So you can see that absolutely. And but all of these are features that, providing that you see it and you apply it, then everything about colitis will be easy, because sometimes you don't see everything as you want it to see. This is another example here of a Toshua script, and I just trying to follow the lumina here to show you the tortuosity of the crypt. It's very tortuous. And then we would accept this as that finding here. This one is slightly obliquely orientated crypts. this one is going as well sidelines. It's not really parallel to the surface. So you can see a lot of these features together, and then the whole scenario and the whole story become much easier. But you can, tortuosity can be sometimes tricky and difficult when you see it. But here in this corner, you can see that this is an angulated crypt. Again, I'm just drawing it and I'm just showing you the angle. It is again 90-degree angle, and this is this form is really an angulation of the crypt. I tend to use angulation sometimes, which will result in this horizontal alignment that you see it sometimes. But if you see the angulation, I describe really in my report what I see rather than anything else. And this is again this close up on that Toshua Script is just to show you these abnormalities. So we will leave this because this is clear, but I will go to the inter-crypt variation in shape and size. And this is now a little bit more trickier because we tend to not look into this in a great depth and details. But in this slide, which I just showed you a minute ago, or in the previous slide, you can start to realize that the shape of the crypt and the size of these crypts are different, you see. So for example, this one is like a حفل دال, for example. في حين this one, yes, it is tortuous. It is, we said this is tortuous, it's okay. This one is round and it looks fine. But you can see that this one is a little bit like an oval shape. And so there is a variation in the shape of these crypts. And this is again another good features, but all of these serve a purpose, because if you see something like that in this wide variation, then you already know you are in the territory of the inflammatory bowel disease, right? Because that's too much. This variation is too much to say that this is only if you say that this is only related to the prolonged infection, then you are wrong, because this is too much. This is not only a prolonged infection. This has to be something like that. Again, another example of this variation in sizes and shape. Look, this here is very small, sitting next to a crypt which is nearly about triple its size. You have also medium-sized crypts present here. We have a very irregular shaped crypts here present into these areas, while you have slightly irregular crypt looking here. What I mean is there is a variation in shape, there is a variation in size. Once more, you just have to pay attention to this variability, because this again can help you a lot to resolve the clinician questions when you started to see these variations going around. And the slide sometimes talks about themselves here. There is a very small crypt or normal size crypt present to a really enlarged crypt here. And this variation, if you will be so naive to consider this as normality, you can see the wide variation of the size of the crypt in this group. And also, since when you accept to see a crypt that looks triangle, جنبه رغيف عيش هنا, it doesn't matter. You see, it doesn't make sense, isn't it? It doesn't make sense that you see all these variability. Yes, there is a crypt architectural distortion, like you have to assess the degree of crypt architectural distortion, because this will help you. لأن زي ما قلت لحضراتكم, yes, the prolonged infections, the prolonged drug-induced injury or drug-related colitis can cause crypt architectural distortion, لكن not to this extensive degree. So unless if you pay attention to something like that, then you will probably not be able to estimate the extent of the problem. So this is one of these things that you have to highlight and pay a very good attention for. And this is again to show you this variability in shapes and sizes. You see there is a very big crypt here sitting to a normal size crypt. This is not acceptable. We should not accept something like that under a normal inflammatory condition that will catch up with that. And I just like to show you an example, one after the other one, to show you that even the subtle difference in sizes, you should still pay attention to it and see and ask yourself why something like that is happening. And obviously, collectively, when you get a lot of these abnormalities, then you get this which is loss of parallelism, which is very famous among us as a pathologist. In معظم الناس, architectural means that you lose the parallelism, that test tube pattern. But you know that the story wasn't only about that. You can see that here, yes, it's not following any particular pattern here. You see there is definitely loss of parallelism. This test tube pattern that you, or this regular spacing between the crypts is not there. But if you pay attention to the fine details, you will see why. You see, because you will see that there is a change in directions of some crypts. You will see some are trying to be obliquely orientated, some trying to become a little bit angulated, some trying to branch. You see, so some areas where the crypts start to space up a little bit between each other. All of these are different features, but they all lead to the impression that there is a loss of parallelism, which is fine, but it is also on its own. If you are not very clever and this is the only things that you know about crypt architectural distortion, then yes, this will help you. But sometimes you get a false impression with it because of the orientation of the biopsy. So you just have to be careful into this context. And this is here again, just to show you the why you've lost the parallelism because of all what we've been talking about. And here you can see very extensive Paneth cell metaplasia, of course, which also give you another features for the chronicity. Even when the biopsy is very well orientated, like here, where you can see the vertical alignment of your crypts, and you can get the sense of losing the parallelism, and that's again related to the fact that some crypts has changed directions in the middle, as here and there, where it gives you that impression that the parallelism that you used to have in your biopsy, somehow it started to be distorted, and then it started to be lost together with the branching and everything. So this is why you tend to get that sense of parallelism. Here it is more difficult when the biopsy get orientated that way. It is sometimes very difficult to judge the parallelism, and a lot of our biopsies in reality, if I sometimes, a lot of times I come to encounter a biopsy that oriented that way, and then you have to look into the regular spacing between the crypts in order to judge if you have a loss of parallelism or not. And it can be tricky and difficult. Like in this case, I will be standing as borderline. I cannot judge parallelism in this one. Maybe it is lost, لكن في نفس الوقت I will try to find out other features, right? Like for example, this one, does anyone has got a name for this? What is this that I have just encircled on the screen? What is that? Anyone? Anyone has a name for these things that I just put a circle around it? Or you can't see a circle? Can you see okay, can you see a circle or not? You can see the circle? Can you see when I draw here? Are you able to see that drawing? Yes, you are able to see the drawing, isn't it? Yes, excellent. Okay, so if you are able to see the drawing, then you can see the circle which I'm drawing here now, which is here. Yeah, this is like it is a multinucleated giant cells, but they are aggregates of them. This is like the phases of what has happened. So let me choose a different color because it might be the color that some of you didn't see. So I will show you, like here, this is the crypt abscess. Here we agree, yes, and then this is the abscess which is about to rupture. You can see the inflammatory cells are trying to come out of this, and then when it's ruptured, then it will go to this, from here, this phase to become that, and this is what you call it, the cryptolytic granuloma. So you can see this transition very nicely here on these slides between the crypt abscess. So you have, of course, some cryptitis in the background, and then it becomes a crypt abscess, and then the crypt will rupture, and when it ruptures completely and disappear, you tend to get these aggregates of multinucleated giant cells in replacement, and these are the cryptolytic granuloma. So these are basically the phases of these transitional things. So I just thought, okay, it's good to show you that in the slide, and this is a little bit different from these fellows. These fellows here are something different. So those and this guy here is a little bit different because these are the proper granulomata that you can get in Crohn's if the history does match. Okay. So I just wanted to verify the point here that do you see this encircling? Do you see me when I mark the granuloma? Did you see that mark that I put around the granuloma? Just before we move on, because I do tend to draw. Yes, you do. Okay. So if you don't see it, I don't know why, but a lot of you do see this. So that's fine. So let's just this is obviously a case of Crohn's, but whenever you are getting these granulomata first time presentation, especially in endemic countries and things, you have to think of other things like the other things that can produce granulomata, including TB, of course, but that's not the setting that I'm trying to express here. But I just wanted to highlight that the parallelism again, because we are in the area of parallelism. So yes, in a case like Crohn's disease, you can get this preserved parallelism, and this is a problem that if this is the only things that you apply, the fact that you can see the crypt parallel, then and you see the granuloma, then your comment on the architectural distortion will be a little bit mislabeled, because you will tell me there is a preserved parallelism, so that translates in some of us mind that as if there is no crypt architectural distortion, because you ignored the list which we have been talking about in the last 1.5 hours about those, but what you focused on is the parallelism. Yes, we have parallelism maintained here, but still it's a Crohn's disease. And obviously, if you start to look into more depths and details, you will find some limited or minor architectural distortion. And this is important, and I keep stressing into these points on and again. And this is again another case. We are still in the parallelism areas because people love parallelism. Yes, so yes, we have parallelism is maintained. Yes, so all the crypts are kind of like parallel to each other. Yes, beautiful, fantastic, fascinating orientation. And this is again, it's a case of of a Crohn's disease. You see, but what you need to address when you are dealing with this, yes, you will see some focal and patchy inflammation somewhere else. But what I would like you to pay attention to, for example, there is a bifurcation of the crypt, which we try to keep a close eye on, and we try to ignore. And in the setting of Crohn's, okay, if I am talking about a Crohn's disease and you started to see things like this frequent, you know, like this is a medium power, and we saw already too. If I search more, I'm sure I will see more. But in that setting, then this is a mild crypt architectural distortion. In the setting of Crohn's, still there is slight angulation. You can take that or leave it here. That is fine, but you then have to weigh things, you see, and then decide on what is that enough to call it minimal architectural distortion. I think it is enough. So if you I think I made the point here that if you are someone who only rely on the parallelism to judge the crypt architectural distortion, and you ignore the angulation, you ignore the crypt bifurcation as a feature of your crypt architectural distortion, then all your Crohn's cases will be difficult because you are not trying to resolve the puzzle for yourself. Right? Crohn's disease is a chronic colitis, and by definition, majority of the chronic colitis will have the crypt architectural distortion. Yes, Crohn's disease, unless if it is fulminant and super infected and has got some CMV on top or whatever, then it can cause then marked architectural distortion. لكن في معظم الحالات بالذات في الكولون في الcolonic biopsies you might get the terminal area might show you the active inflammation and the decreased villocyte. لكن لما بيجي لك بقيه الcolonic biopsies في الكرونز, because it might be limited or mainly active في الterminal ileum, then you might interpret those in the right side of the colon as normal, while in actual fact they might not be particularly as normal as you thought it is. It's only because you tend to ignore the slight problems of the architectural distortion. And that will lead us to another features of the crypt architectural distortion, which is the crypt atrophy. And I told you المرة اللي فاتت إن في بعض الناس بتحط الكريبت اتروفي لوحدها كانتيتي لوحدها خالص, ولكن في معظم المودرن pathology papers, especially in the last 3 or 4 years, people now started to say, in actual fact, you know, it is better to consider crypt atrophy as part of the crypt architectural distortion. In this example, it is fascinating and fantastic example of the crypt atrophy, and you can see the distance, يعني صحراء شاسعة ما بين المسلز وما بين نهاية الcrypts, and this is definitely crypt shortening, and crypt shortening is a sign of a crypt atrophy. So this is one of the things that you know that there is crypt atrophy when the crypts are short. Then it is the features of that crypt atrophy. So this is one of those ones that you identify. المرة اللي فاتت في وسط الكلام قلت لكم بس you have to be slightly careful when you are assessing crypt shortening في الrectum وفي الcecum. Yes, for rectum with cecum, you have to be a little bit careful because sometimes in the rectum and the cecum, these crypts might go down and end somewhere here, right? So you might get the crypts ending, you know, not exactly at where the muscles is, so they don't touch. Sometimes in the cecum and in the rectum, you might find a little gap, but this will be in this particular site. So you have to be careful really when you assess, but it's not going to be a wide gap like this. It will be a very small gap, but you just have to pay attention where you see it. You don't tend to see this gap in the descending colon, in the sigmoid colon, in the transverse colon biopsies. وفي الغالبية العظمى في معظم البيوبسيز for the inflammatory bowel disease or colitis, you will have a series. So you'll have a cecal, ascending colon, transverse colon, going all the way to the rectum, and then you will be able to judge it. So this minor histological variation is quite important to pay attention to. So here is another example to show you the crypt atrophy, and this is what I wanted to highlight, that people tend to sometimes ignore the crypt atrophy because they judge the density of the crypt, and they don't see crypt shortening as a crypt atrophy, as a, you know, and then they ignore it because they see the density of the crypt. The number of crypt is fine. Yes, there is architectural distortion, yes, but they tend to ignore a little bit the atrophy into that case. This is another way to assess the crypt atrophy. And this is when there is a spacing in between crypts. You see, like you get a whole area that really doesn't have crypts at all. And sometimes you have to judge it in between, although we have a very faint crypt here present, just about to fade and disappear. Like in the US, this is this crypt spacing, which is another features for the crypt atrophy. But even with the orientation like this, very, very poorly orientated, if you wanted to judge, like you can see the distance to the muscle is too far, and then that tells you automatically that there is a crypt shortening, but there is a spacing as well between the crypts, and that tells you I am crypt atrophy. So crypt atrophy is a term, as you know, we will consider it for the spacing out when they stay apart from each other, or when they are short. Then you can use both terms to use the crypt atrophy as a feature. Here in these examples, you get also crypt atrophy in ischemic and radiation colitis, where the lamina propria will become a little bit more densely eosinophilic, like what you are seeing here. It's becoming pink, really pink stroma, and then you have to think of other things that can lead to the equations. But here, this gap is again too much, and you can then consider this as a crypt atrophy. The one thing that I wanted to tell you when you assess the crypt atrophy, that if you are dealing with an acute colitis situation, then you have really to be careful, because in acute colitis situation, you might get the spacing out between the crypts, but the crypts might be just spaced out عشان خاطر expansion of inflammatory cells, right? So you have to be able to judge this. Do you see the atrophy because you are getting basically, do you see the atrophy because you are getting a lot of inflammatory cells, then they spaced out, or do you have a true atrophy because there is a crypt dropout and you don't see any more crypts to fill up the space? So all of these are features that you have to apply and consider, and then be careful that don't judge crypt atrophy, don't just jump to the conclusion that there is a crypt atrophy. No, there is. You see, those two crypts, for example, are very close to each other, okay, somehow. But if you go here, these two crypts has become far, okay? So what's happening here is probably an expansion of the inflammatory cell infiltrate that led to the fact that you feel that there is a spacing out, okay? there is a spacing out between the crypts, and this is different from the crypt dropout. You see, this is a little bit different because you need, but again, it's a difficult areas, but you need to make that judgmental call by putting this space in the text of what really is happening in the surrounding biopsy. Does it look infectious more, or does it look inflammatory about this? If you are calling crypt atrophy in acute infectious colitis, then that's madness. What you are seeing as a spacing out of crypts in acute infectious colitis will be more of the expansion of the lamina propria by inflammation, which pushing the crypts away from each other, rather than losing crypts which was supposed to be in a situation like this. So low power is good to assess this crypt atrophy, because you will be able to see the relationship to each other. You can see where the spaces started to be created, and if you can see the density of inflammation. If you feel like, for example, I will stand by two areas, yes? So I will take you in this area here in blue, and then I will take you to another area here in green, right? Now, if I tell you that this area here in blue is, we don't have enough crypts, بس لما نبصي على الانفlammatory cell density, they are not as dense as the other side here. You see, this I might ignore this and don't call it crypt dropout or atrophy in an area like this, because there is a dense inflammatory cell infiltrate. There are sheets and sheets of inflammatory cells. في حين إن هنا there is a little bit of a spacing out, لكن the density of inflammation is much less. Okay, that's not explained by inflammation alone. And then yes, then I will consider this as a crypt dropout, and which is one of the features that you will judge, and you will tell me there is a crypt atrophy. So yes, it is important into that sense. Now, it is important as well in the surveillance biopsies, because every time they send you about a treated sample, you might find the crypt atrophy, لكن the degree of crypt atrophy is important to compare it from من البيوبسي بتاعت 3 شهور فاتت للبيوبسي بتاعت المرة دي, because if you're getting less crypt atrophy, then this might mean that your treatment is working. You're getting somewhere into the equation. So again, just remember yes, they can be very close to each other, but when you remember the spacing out between the crypts, so you have to think a little bit more. If it is related, is that related really to the inflammation, or this is related to the fact that we don't have, or related to some phenomena that I have here, that it just happened that you didn't get the crypts in the view. Okay, so what happened to this crypt here, that this crypt is should have been, the rest of it should have been here, like, and it didn't come in the view. So don't just judge this area as a crypt atrophy, because it isn't a crypt atrophy. There was a crypt here that was just going in continuity with this, but we don't see it, right? So don't just judge this. Also use a lot of common sense when you're trying to assess this. So not every time you look into an empty space, you will tell me, oh, there is a crypt atrophy. And then the other architectural distortion, which I would like also to talk about, is the irregular or vellus surface, which we all know it, but we don't apply it. يعني أنا في المحاضرة ونص بقى في الساعتين إلا ربع اللي احنا اتكلمنا فيهم لغاية دلوقتي من المرة اللي فاتت للمرة دي, I showed you a lot of slides with irregular or vellus surface. A lot of them were there, right? But it didn't catch your eye, right? It didn't catch your eye unless if you search for it. And once you start to search for it, then it will catch your eye. You see, the vellus surface of the large bowel mucosa is not a normal thing. Okay, this is not normal to have this broad vellus, and then you get this little villi and a little bit thin, and the surface really is really very irregular in general. This is an architectural distortion, okay, and this has to be really looked at. And what we pay a lot of attention to the atrophy, we pay a lot of attention to the dilatation, the angulation, abscesses, cryptitis, but what we forgot this irregular surface. And this irregular surface is very important because it tends to happen more, much more with ulcerative colitis. And it might be a clue. Sometimes if you're struggling between a case of ulcerative colitis or infectious colitis like amoebic dysentery, for example, where there's architectural distortion, it has been sitting there for كل ما العيان يخف تجيله تاني، كل ما يخف تجيله تاني، عشان عمال يرمرم وياكل اكل من الشارع طول الوقت. فاميبك يعني الاميبا عايشه متعايشه معاه، فبالتالي it can be difficult, but the surface might resolve a puzzle like this for you, but you didn't pay attention because all what your attention was going for the cryptitis, the crypt abscess, because cryptitis and crypt abscess, they are nice to see. Like here, oh, you tend to spend hours and hours to try to find that polymorph attacking the crypt so you can put the word cryptitis in your report. That's absolutely fine, yes? But what you ignored, and instead of searching for this polymorph, you should have not ignored this surface, okay? Which was very irregular surface. You should not have ignored this because this probably is the main clue of your biopsy here, and this is what you have ignored into or failed to recognize. Sometimes when it is a little bit subtle, it can be difficult, but again, this is not normal. These are broad, short villi. This is not particularly normal. It's subtle, it is early, but this is not normal. I would pay a lot of attention, or I will be basically very aware. I will wake up as soon as I see the surface has got something like that. But in resection specimen, you can get it easier, and you can see that the irregularities and forming this inflammatory pseudo polyps, or you see, or polypoidal mucosa, these still irregularities can be a clue in the resection specimen to know that, okay, then I'm most likely dealing with a UC, not a Crohn's disease. And we know that sometimes it can be hideous in fulminant colitis to differentiate between the two, but sometimes the surface irregularities might help to give you an idea of what you might think of. Here again, it can be subtle, I know, and some people might think that that is crazy. It is crazy, yes, but look, there is a villi here, yes. Can you see these vellus here? And then there is another one here, which is a little bit more obvious. Okay, so these are subtle, but it's still there, and this will help you to direct you in the directions of inflammatory bowel disease, because these mucosal irregularities, yes, it can happen with ischemic, but in ischemic, it happens in a different format. We will be visiting this in later, but what I'm trying to say, that if you tend to ignore the surface irregularities and the vellus pattern in the large bowel mucosa, then you will almost always struggle. if I just want to show you here, it is, we love this, yes, we love the crypt abscesses, yes, here and there, okay, and then you think, okay, can it be, is that a Crohn's or infectious colitis? But look at the surface here. The surface is very regular, okay? That's a very regular surface. This is completely different from the surface which I was showing to you a few minutes ago. And of course, my first impression then will be about this biopsy, that it is most likely infectious colitis, okay? So most likely I will consider this as infectious colitis. Now, I just will take you back to the previous example, that the dilated crypts, are you telling me that this is a dilated crypt here? This is a vellus. We agree? There is even a fibrovascular cord trying to go here. Yes? So this is not a dilated crypt as such, but there is an irregularity in the surface. I'm just trying to show you how subtle things can be, but usually in normal circumstances, you will see the proper irregular surface, because that is the norm, to see the irregular surface. But here, so based on the surface alone, even without touching these slides, I will be more heading towards this to become an infectious colitis, because I don't see that surface irregularities which will take me in the way of UC, for example. Here is another example of an irregular surface, but this is a different type of irregular surface. You see, yes, I agree with you that there is an irregularity of the surface here, but what is this? What we are looking at here in this biopsy? What is that? Anyone? Anyone? Okay. So some of you said erosions, ischemia, pseudomembrane. Yes, دكتورة أمل الله يفتح عليكي والدكتورة فرح الله يفتح عليكم. Yes, this is the pseudomembrane on a biopsy. هي المشكلة إن sometimes in the biopsy, this is all what you might see. And if you don't pay attention again to the surface, or you consider that this is only a surface erosions, which is a common mistake that we can all fall in, then you will not see that this was a clostridia, and then the patient is struggling for another 3 or 4 weeks. Still the patient will get the toxic megacolon, and then will get a total colectomy. And this is because you failed to recognize that this irregular surface with a pseudomembrane, and you didn't really pay a lot of attention. Then you will just in the back of your mind thinking about other stuff. But here I just wanted to show you the example of, and here is the close-up of that pseudomembrane to just yes, and it is like the volcano eruptions, like what the textbook would love to assess. 2 points that you need to always remember, that we don't, of course, judge the atrophy in relationship to the lymphoid aggregates. Like here, there is a lymphoid aggregates and even lymphoid follicles with germinal center formation here, because this is an area, there are, we all know that in areas like this, you don't judge the crypt architectural distortion, and you don't judge crypt atrophy. When you see something like this, you don't. It's as simple as that. You just cannot judge the architecture in that field, full stop. Even if you see architectural distortion, you just can't, okay? And this is one thing to remember, but this is a little bit different from this, which is really what we will call it lymphoid aggregates, which is a common finding that you tend to see in ulcerative colitis again. So if you ignore something like that, or you just looking at it as a crypt atrophy, but you didn't realize that this was a lymphoid aggregates and you will see too many of them, then you might be talking more of a cryptopathy. But these lymphoid aggregates, you will say, it is common to find in ulcerative colitis, but you are not paying attention to this because all of your focus is there is an atrophy, why this area doesn't have crypts while we can see the crypts are back to back elsewhere, then there is a crypt atrophy. No, it isn't. It's just expansions by lymphoid aggregates, and these lymphoid aggregates, when they are frequent, especially toward the base of the crypt, they are common to see in ulcerative colitis. Now, if you see the lymphoid aggregates below the muscularis mucosa, then they are more to do with the Crohn's, or you see it below the muscularis propria in the resection, then it's more to do with the Crohn's. So lymphoid aggregates, again, depends where you see them, then it carries a lot of weight according to where you do see them to make you make the decisions of which part I will go towards into that sense. And then this one, although it is not mentioned in the table of the cryptarchitectural distortion, but to my eyes, still a cryptarchitectural distortion. And this is what we call it a superficial crypt damage and weathered crypts, which is a very specific features for ischemia in ischemic bowel. And what it is, I just will show you how difficult it can be in a biopsy to decide on ischemia, because we like to see it more in the necrotic bowel when everything has happened and the patient's got peritonitis and had the resection of the colon. But one thing that we tend to ignore it when we see it on our biopsy, but we don't pay attention to it because we are not trying hard enough. This crypt here has got a problem, as well as the crypt next to it here, right? Because the base of these crypts, the base of the crypts here, the base of the crypts, as you are able to see here, has got the epithelium, but in the surface you kind of lost it. And look here again, in the surface you are losing it. You can see that there is like a shadow of that crypt, but you've lost it. And then I will just pay a little bit of more attention to other areas. Look here. What's happening here, right? This is not something that you are trying to imagine, that nothing is happening. There isn't a lot of inflammation to start with, yes? There isn't a lot of inflammation in the lamina propria. In actual fact, the lamina propria looks a little bit more eosinophilic, like started to have a little bit of more collagen somehow. But there are few findings here that this is not particularly an irregular surface as the other one that I showed you in previous examples, but you can see that the epithelium is lifted out. So this is not normal. This epithelium shouldn't be flying in the air like that. When you see something like that happening, that means that there is a pathology going on around these areas. And then the other things here as well, that the crypts as well here, like eaten up in the superficial part, damaged. And this is what you see in the ischemia. It's still giving you a little bit of irregularities on the surface, but these irregularities is related to this form of ischemia that you are able to see here. Now, let's not forget that the ischemia in the bowel can happen with a lot of things, you see. So you can see this ischemia in the congestive heart failure, which a lot of patients do have. You can see it in people with atherosclerosis and extensive atherosclerosis. So what I mean is that it's not necessary, it has to be an acute, we are not talking about the acute ischemic event. These are like chronic ischemia, but it gives the patients a lot of malabsorption, a lot of abdominal distress, a lot of symptoms will be related to this indigestion after eating, all of this bloating, all of these symptoms will happen. But you see these irregularities on the surface, the mucosa is coming out, the crypt here is eaten up. All of those are features that we see it with this ischemia. And if the problem of this finding in chronic ischemia, I will tell you that you get biopsies from cecum, ileum, ascending colon, transverse colon, and everywhere, right? So from all these segments, and then you don't, you miss something like this because sometimes it is very focal. And the reason why it is focal in some of the biopsies, especially if it is early, because it only happens around the flexural areas, right? When the bowel is kinking. بما معناه إن it can happen around the hepatic flexure. It can happen around the splenic flexure, and it can happen around the kink between the sigmoid colon and the rectum. فديت معناها إن لو كان الclinician thinking that this might be an ischemia, and all what she is doing إن هي عملت الاندوسكوب وبعتت لك حالات من بعتت لك بايوبسيز من التيرمينال اريوم والسيكم والاسcending colon والtransverse colon biopsy and then descending colon and rectum, then it might not be diagnostic, right? لأن it is segmental disease in the early phases. Ischemia can be segmental, and what I mean by that in terms of finding, that in the early ischemia, you need to direct your clinicians to get you biopsies if they are thinking of ischemia and you are worried about ischemia. Then you need to focus your attention to the hepatic flexure biopsies, to the splenic flexure biopsies, and to the rectosigmoid biopsies, where there is the junction, where there is a kink between the rectum and the sigmoid colon. So this is where majority of this finding you will see it, and this is just a close-up on the mucosa to show you that the inflammation probably wouldn't have helped you, but what would have helped you to assess, to see that fallout of the epithelium on the surface, the eosinophilic mucosa, and the crypt weathering when the epithelium, sorry, with the crypt, it is the superficial crypt loss. Here again, the superficial part of that crypt and that crypt, that's a close-up of those couple of crypts, it is gone. You see, this is ischemic events, and this shouldn't pass lightly. You don't let this something like that pass in your biopsy lightly. So when you put all of those, then you can say, mention the word of, when you find it, you know, when you assess all of what we talked about, then you will tell me the first sentence of your report. That is the first sentence: large bowel mucosa with abnormal crypt architecture. This is what it is, or with crypt distortion. So all what I have explained in the last seminar and this seminar is how you will put that sentence. And that sentence only means chronicity, and it can happen after a prolonged acute, or it can happen with all the other causes that we have demonstrated in the big list, apart from one or two which don't tend to have that. But what it is, it tells us now there is a chronicity, there is a mandate that we need to try to do more effort to name this biopsy. And that will take us, of course, to the next seminars, which will be, can other than diagnostic clue help us in the equations and decrease the confusion level? Okay, if you know how to assess now the architecture fully to put the sentence of architectural distortion, then this is a chronic disease. Then you need now to understand as well how you will understand the other diagnostic clue, which will be the final lecture of these limited seminars, inshallah, bi'idhnillah ta'ala, next week. I hope that for those who tuned in النهارده ان المحاضرة كانت مفيدة. I know there is a lot of repetitions, لكن sometimes it works that way. يعني الله يفتح عليكم بالعلم ويزيدكم علما جميعا، ويا رب يعني إن شاء الله بإذن الله بعد المحاضرة الجاية تكون الأمور شوية كتير أسهل من ما كانت بالنسبة لل initial assessment of GI pathology, so it will make your life much easier in the future. So we will assess a lot of more clues inshallah bi'idhnillah next time, but I can't, because I promised for people not to get bored, to make short series from now on, and this is why I have now decided to make them only short snaps of limited seminars على أساس الناس ما تملش ويستبوا أخوك ويقولوا الدم التقيل ده. فمعلش اعذروني اليوم احنا ما هزرنا كتير، لكن it was intense lectures because I want you to take the matters very seriously, and I think the things will go better inshallah for the future for all of you. We will I will try to do the esophagus in terms of Barrett's and dysplasia. We can try to do that. For the book, it will the thyroid cytology. It will hopefully come very, very soon, inshallah. So I will let you know as soon as it comes. Yeah, salivary glands. It is. I love salivary glands, and we probably will be able to do that as well in the future. There's no problem. We will do, as I said, short, limited series. So, and I think limited series will be more digestible for all of you, and you will be fine. Polyps, I will do polyps, Dr. Heba Hader. I think this is a good suggestion, and I think we can do that also very soon. Inshallah بإذن الله. I hope that you يعني فعلا كان في استفادة عامة، لأن أنا I don't know بصراحة إذا كانت الناس يعني بتستفيد ولا لأ، لكن يعني I think يعني في basics. أنا عارف إن طبعا في ناس كتيرة very experienced موجودين معانا، and يعني بيعتبروا اللي احنا بنقوله ان هو ده كله كلام لعب عيال وكده، لكن I get shocked in real life لما بشوف يعني ناس كبار في الخبرة وقدام، وفي نفس الوقت ما يعني they ignore these subtle things, they ignore it, and it leads to problems, right? It leads to a lot of problems, and this is what when it goes wrong. المرة اللي جاية إن شاء الله دكتورة عزة في السيمينار اللي جاي I will differentiate between the infectious colitis and early inflammatory bowel disease, because this is a very important area, and yes, by next lecture you will understand a lot of how you can differentiate between the two.